and welcome back, and welcome to our cardiology panel. You obviously you don't have a health conference in the middle of a once in a century global pandemic without talking about that pandemic. But it's important to note diseases don't just stop because a new virus emerges. Unfortunately, people are still getting sick from all kinds of illnesses, and that, of course, includes the leading cause of death among Americans, which is heart disease. And on top of navigating the complexities of heart disease, we're still trying to figure out what impact the coronavirus has on the heart in the long term. So it's a complicated picture, but fortunately, we have three top experts in the field to talk not only about the virus, but also about their work and some of the developments in their field that will have a far-reaching impact both here and abroad. So wanted to introduce our three panelists and give a bit of background on them. We have Dr. Stephen Nissen, who is the Chief Academic Officer for the Heart and Vascular Institute at the Cleveland Clinic. He also teaches at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and is also a past president of the American College of Cardiology. And his contributions to scientific literature include nearly 600 journal articles and 60 book chapters. And he's also the co-author of a book for patients with heart diseases called Heart 411. So welcome, Dr. Nissen. We have Dr. Brian Choi with the George Washington University Hospital, or George Washington University, where he's a professor of medicine and radiology, chief medical officer, and co-director of advanced cardiac imaging in the Division of Cardiology. He specializes in non-invasive cardiovascular imaging, and his clinical interests include the prevention and treatment of coronary artery disease, congestive heart failure, and valvular heart disease. I hope I pronounced that correctly. Welcome, Dr. Choi. And last but not least, we have Dr. Yves, who is Chief of Cardiac Surgery at Children's National Hospital and co-director of the Children's National Heart Institute. Trained in Belgium, South Africa, Canada, and the UK. He previously served as Deputy Director of the Cardiac Surgery Unit of the Royal Children's Hospital in Melbourne, Australia. And with more than 350 publications and over $7 million in grant funding, he has become one of the most academic, productive surgeons of his time. So welcome, gentlemen. Each of you specializes in very distinct areas. So I'd like to start just by exploring some of what you do. So Dr. Nissen, let's begin with you. You work with pharmaceutical companies to develop new therapies for cardiovascular diseases. Now, I'd like to talk about two interesting treatments you've worked on that are very relevant to a significant portion of the population. One involves something called lipoprotein a heart risk factor that, as the New York Times pointed out, even many doctors know little about. And the second involves a treatment that could help people who are not able to tolerate statins. So can you just talk to us a bit more about these two areas of research that you've worked on?
Well, thank you very much. And it's great to be here with you and with this great group of experts. So lipoprotein A is one of those risk factors that, as you say, doctors know very little about. And unfortunately, only about 1% of the people that actually have this risk factor know that they have it. It's a cholesterol particle that is particularly noxious. It has two components, and these two components promote both the accumulation of plaque in blood vessels, but also they promote inflammation and clotting. And as a result, that if you have this abnormality, you have a very substantially increased likelihood of developing premature heart disease. We're talking about people having heart attacks in their 40s. About 20% of the world population has this abnormality. That's 1.4 billion people. It's 64 million in the United States alone. It's been absolutely untreatable. Nothing about diet, exercise, lifestyle, or anything else can lower this risk factor because it's genetically determined. So the only way to beat it is to turn off the gene. And that's exactly what we're doing. We've developed a therapy that's now in phase 3. That's the final phase before approval. That is fundamentally known as a gene silencing therapy. And what it actually does is it stops the translation of the message coming from the gene to make this abnormal lipoprotein. That term, gene silencing, applies to several strategies, but this one is moving along very quickly, developed by a small company in the US, now picked up by a large Swiss company, Novartis. And I'm directing a 8,000 patient trial being run in 42 countries at 1,000 sites that's designed to find out whether this drug, which lowers levels of this abnormal lipoprotein by about 80%, whether that lowering can reduce the risk of death, stroke, and heart attack. We're very, very excited about this. And I see that we're getting Zoom bombed by your lovely cat in the background. So we'll say hello. So that's lipoprotein little a.
We've joked that we are gonna at some point create a hashtag for my cat, because when I do webcasts and webinars, I can't even close the door anymore. He always wants to shine in the spotlight. So I've given up. He just comes and goes as he pleases.
So in 5 minutes or less, that's what we're doing about lipoprotein little a. And there are a lot of more details, but that's the big picture.
Great. And now could you follow up and talk about, obviously statins are such a common treatment, but there are people who can't tolerate them. What has been some of your research to help these particular people?
Well, we've done several studies. We did one that we published in the Journal of the American Medical Association a couple of years ago, using this new class of injectable cholesterol-lowering drugs, the PCSK9 inhibitors. They're taken either every 2 weeks or once a month. And we showed that the majority of people that were unable to tolerate statins could tolerate these injectable drugs. But there's something new that's happening. And a drug was approved recently known as bempedoic acid. And this is a drug that works by a mechanism that is somewhat similar to statins, but it's a drug that only gets activated when it gets transported into the liver, which is where most of the cholesterol in the body is manufactured. Since it doesn't get into muscle, it only gets into the liver, it can't produce muscle-related symptoms. Now, in order for this drug to be successful, we have to show whether it reduces the risk of the things we really care about, which is not necessarily lowering cholesterol, it's preventing heart attack, stroke, and death. And so I'm running another trial that's also global. It's in 14,000 patients. It's fully enrolled, and it's in the follow-up phase. And it's what we call a cardiovascular outcome trial, classical design, and we give half the patients placebo, and that's a sugar pill, and half the patients this drug, which is taken orally once a day. And then we're going to find out whether it can lower the risk of death, stroke, and heart attack. And we're very excited about it. It'll be the first new oral cholesterol lowering drug in quite a long time. And it could, play a role. Now, please keep in mind that statin intolerance is controversial. There are a lot of people who think that the vast majority of patients who think they can't tolerate statins can tolerate them. And we've studied this quite extensively. The problem is, if you've convinced yourself you really are not tolerating the drug, getting those patients to take these drugs is very, very hard. And so that's why we've got to develop alternatives.
Well, thank you. That's very interesting. My cat obviously finds it fascinating. So I'm sure very relevant to a lot of our audience. So Dr. Choi, going over to you, as I mentioned, your research has specialized in non-invasive cardiovascular imaging, and you've been able to use this knowledge to help people in some of the world's poorest countries through a nonprofit called RadAid. Can you talk more about some of your work through this group in countries such as Honduras and how you've been able to strengthen fragile healthcare systems in these countries, but in a sustainable manner?
Well, thank you, Anna. And it's a real pleasure and honor to be on this panel to discuss the important work we're doing collectively in trying to lower the impact of cardiovascular disease in the world. No one would have thought, and we are all working so assiduously to make sure that heart disease is no longer the #1 killer, and we never would have thought it would be, because it's been surpassed by COVID at periods during this past year. But needless to say, cardiovascular disease still remains the #1 killer of people around the world, of death and #1 cause of death and disability. And it's particularly pronounced in low-resource countries. There's 2/3 of the world that has no access at all to medical imaging. And you think about the important role that medical imaging plays. Think about a chest X-ray, or in our field, it could be stress testing with imaging, or CTs, or echocardiography, which is from ultrasound, is unavailable in much of the world. And to really make headway into combating disease, we're going to need the use of more medical imaging. But every country is different. And I started getting involved with this about 10 years ago. We have a medical mission in Honduras, which is a country in Central America, that there's a lot of cardiomyopathy or heart failure, mainly because of the residual effects of Chagas disease, which is a parasite-borne disease that causes damage to the heart as one gets older. But to really identify patients that would benefit from those that might need an implantable defibrillator, for example, you kind of need that imaging support to differentiate who would benefit most from those kinds of devices. So what we did is, we had a mission team down there, and we would send the images back to the U.S. to be able to determine which patients would benefit the most. And what we found, that got me involved with RadAid, which is primarily led by radiologists. However, one of the things that we've seen is that in every country has a unique profile, and so it's not like one solution that works in one place would necessarily work in another. And so we take an approach where we look systematically at all the resources that might be available in a country and make sure that we're matching up the solution to what will make the biggest impact. Decades ago, very frequently, well-minded, well-meaning folks would, donate quite expensive equipment in places that may not have the electrical grid infrastructure to support, a CT scanner. Certainly, the parts for maintenance, or necessarily have the radiologists and technicians necessary to operate such equipment. Some places have that stuff, but they may not have a trained radiologist. Or, in other places, the infrastructure might be good, but there might not be the downstream care necessary to take care of the patients you identify with disease. For example, if we were to have broad-based mammography screening for breast cancer detection, but there's no pathologists to read the biopsies, and there's no surgeons to do the necessary surgery, it wouldn't really serve the necessary purpose. Or if we were to have screening for patients that would benefit from childhood pneumonia, and if there's no downstream ability to deliver antibiotics to those patients, it again would be problematic. So we've taken a country by country approach, really looking systematically at what would be the most necessary thing. Sometimes we realize everything's good here infrastructure wise, but there's just no radiologists. It's kind of, you have your internists or just general physicians that are trained to read radiographic images, and might be benefit to have a training program in place to have higher level of expertise. So other countries, it might be a matter of what's really limiting the growth is inadequate image storage facilities. So in some countries we've targeted the implementation of PAC systems, which are ways that we can kind of store images so that way it can be referenced, and because there comes a limit to the amount of film that you can keep around. So that's the approach that we've been taking with RadAid to make sure that medical imaging is going to be necessary. We're really going to put a dent in cardiovascular disease in low-resource countries, and finding out what is going to provide the biggest bang for the buck and most sustainable is something that this organization is really aiming towards.
Well, that's interesting. I mean, as you said, we certainly take for granted a simple thing such as a chest X-ray and don't think about how revolutionary that can be in certain countries and all of the components that are necessary just to even make that happen. So certainly fascinating work and fascinating group. So Dr. Didekam, I would like to throw it over to you. Now, you take on the most extreme heart conditions in the youngest of patients. So can you just talk more about what motivated you to become a surgeon who operates on babies' hearts, and also what motivated you to come here to the U.S. after a career of working abroad? Oh, I just have to unmute.
I think you need a special profile to become a pediatric cardiac surgeon as opposed to a cardiac surgeon. What attracted me to adult cardiac surgery was the level of technicity you need, and microsurgery and the fine motion and the difficulties and technical challenges. There's an emotional component in pediatric heart surgery that you have to accept. When I started my training in the 90s, I was counting that we were probably out of 10 babies that we were seeing. And that was much better compared to the previous 2 decades. And now we at a mortality of, if you're a good center, around 2%. So there still has been a vast improvement. The reason why I personally picked that job, probably if I was to tell you that in my spare time I'm a cave diver, and when I was adolescent, I like to do ice climbing. I probably have a profile in taking a risk and playing with death in my personal life that influenced my choice in the work. But then why did I come in DC? I think I've come to a point, in my 57, I'm the point to which I'm a mature surgeon. And I think I've done a lot of research, and I know how to do certain things. And I'm at the stage of my career where I'd like to change things and spread the word. And so I can do the best possible job in Australia. When I go to meetings and I try to convince people, I'm still the guy who's talking for some time, but who's coming from the other part of the country. I'm that guy in Australia. So medicine is still mainly North American. And at the end of the day, you want to change things, you have to change them from the inside in North America. That's my challenge. And what is the challenge? Well, the challenge is, as you said, the most severe conditions. The thing that I'm the most involved in is the treatment of babies with single ventricle. So you and I have 2 pumping heart chambers, 2 ventricles, one that pumps into the body, one that pumps into the lungs. Some babies have one that is so small that it doesn't count. So they have only 1 pumping heart chambers. And so we can arrange things by a series of operations and maintain them alive. And the biggest part of my work has been to demonstrate that actually they have much better future than anybody could have imagined. But there's a lot more work to be done. In an early stage of life, imagine we've done operations that maintain them alive, but the mortality of the one who have a single right ventricle, a pumping chamber that normally pumps into the lungs, the mortality is still 30%. So it improved from the 80s, 90s to 2005. 2005, everybody reached a plateau. Australia, Philadelphia, Toronto, Cincinnati, you look everywhere, there's still no progress. So 15 years, almost 2 decades, and not a single dent in the 30% mortality. You look at the fields of medicine that haven't made progress during that time, and they're not many. And so that's what I want to break that ceiling. And I thought that the Children's National in Washington would give me the good opportunity for that. I have plans. You're still on mute as well. Anna, you're still on mute.
Anna, unmute.
Oh boy, but cats and mute still, even after a year and a half, these virtual conferences. Obviously, I have not mastered all of them, all of the glitches. But well, thank you for that. I want to, ask what is on a lot of people's minds, which is, of course, going back to the pandemic and its effect on the heart. There have been a lot of studies, a lot of theories, speculation, and obviously this will continue to be examined for a long time to come. But, Dr. Nissen, what have you so far observed and learned about the virus's impact on the heart and various conditions?
Well, there's both a direct impact and there's actually some indirect impacts. So let me talk about the direct ones. We've seen a number of patients come in with what we believe to be myocarditis. That's an inflammation of the heart muscle due to the COVID-19 virus. And it's quite fulminant, and patients literally are dying in front of our eyes. And what's really interesting about it is that we've now found a way to at least salvage maybe up to 50% of those patients and get them through. We put them on the heart-lung machine. It's a technique called ECMO, where we are circulating the blood and we have an artificial lung involved and used by cardiac surgeons now for many decades. And it seems like the heart muscle inflammation goes away within a week or two. And many of those people will recover, but you've got to be really aggressive early on to support them through that. The indirect effect is actually more catastrophic. And the indirect effect, and we've written about this, is that patients for many months would have heart-related symptoms and they would not come to the hospital because they were afraid of contracting COVID in the emergency department. And we wrote a case report of a patient that stayed at home with a heart attack, and then they ruptured a hole between the left and right ventricles of their heart, which was nearly lethal. The patient did survive, with some very good surgical intervention, but that patient probably would not have gotten so sick if he had come to the emergency department. And so we've really had to get the message out that if you're in an area in the world where there's still a lot of COVID and you get chest pain, that's the typical chest pain of a heart attack, you don't stay at home. The risk of trying to ride out a heart attack at home is a lot greater than the risk of getting COVID in a carefully managed emergency department or an intensive care unit. So people are delaying care. And that's one of the reasons why we've had a lot of problems with heart disease. And I'm sure that, Brian, you've seen a very similar phenomenon.
Yeah, well, I'm very glad you raised that point. I know we are still studying mortality rates and how when you tease out COVID, they have risen in many categories, heart, cancer, and so forth. As you said, for the simple reason that people have delayed care. So, Brian, I want to go over to you with a similar question. What have been some of your observations in terms of COVID's impact on the heart? And also, I wanted to ask you, we've seen really this explosion of international telemedicine, that has happened during the pandemic. And of course, that has connected people in a way they've never been connected before, but at the same time, it has some of its limitations. And I know you have some thoughts on that. So could you also talk about kind of the pros and cons of this telemedicine revolution that we're seeing?
Sure. Certainly in the early days of the pandemic, we witnessed the same things that Dr. Nissen described, which is that there was a lot of fear about coming into healthcare facilities. People were coming in sicker, but when it comes down to outpatient-based medicine, like the traditional office visits, those visits just plunged as well. And in fact, in our city, where I'm located in Washington, D.C., the local government also put additional restrictions that made it difficult for our patients to have access to us. So that was really, we have been in the telemedicine business at GW for over 2 decades now, but it was really a niche application, mainly because of the regulatory barriers involved with providing telemedicine care. I'm located in Washington, D.C. Washington, D.C. is what I would call a border city. We're surrounded by Maryland and Virginia. And despite the fact that my location here in Foggy Bottom, which is right up against the Potomac River, I'm close. I'm a stone's throw away from Virginia. Well, a very strong stone's throw away.
Depending on traffic.
Yeah, I'm not licensed. Well, I personally am licensed in Virginia, but many of my colleagues are not licensed in Virginia. And so prior to the pandemic, if their patients that live in Virginia want to see us, they wouldn't be able to do that because Virginia would restrict, the Commonwealth of Virginia would restrict our ability to provide telemedicine services there. Now that we're under the national public health emergency, a lot of the restrictions have been kind of lifted, but there is still this state licensing issue that still needs to be resolved that prevents us from providing care across borders. Now, prior to the pandemic, that's why we had these niche applications. We provided telemedicine services to the Amundsen base on the South Pole, maritime services around the world, like these shipping, container ships that float around the ocean. Those are our main telemedicine contracts. A prison care, that was another niche that we had. But routine care, like the typical care that you want to see when I want to see my doctor, we really didn't do that too much because there's too many regulatory barriers. In fact, Medicare, the main government payer, you have to be in a rural location to be able to provide telemedicine services. So now that that's been lifted within the U.S., we've been providing telemedicine services for our patients that are staying at home, protecting themselves. We had a number of providers that felt necessary to stay at home too, to protect themselves and their family members during the early days of the pandemic. And they were still able to provide care using the telemedicine platforms that we had. Now, on the international standpoint, it becomes even more complicated. So in the early days of the pandemic, we went to our compliance officer and our legal department and said, well, we have a number of patients that are overseas as well. Mm-hmm. How can we provide telemedicine services? And that's where it became complicated in that our legal department or our compliance officer just didn't have the bandwidth to look up the rules in every single country that's out there to understand what regulations we may be violating. And certainly we are unaware of the penalties that are involved. So we do not provide telemedicine services to patients that are located overseas, where it's just the doctor in Washington, D.C. and the patients that's overseas, because frankly, we're just not familiar with the regulatory requirements that might be there, and we don't want to violate the laws of another country. Right. But we do feel comfortable providing consultative services to another physician, particularly because that's more like a doctor to doctor. So it's the doctor in the other country that's providing care to the patient. And also we provide kind of second opinion services, meaning if a patient has all their studies have been done overseas and wants us to evaluate whether they might benefit from coming here for their care, we'll do that as well. But that regulatory barrier remains a very real one to prevent more typical office-based encounters. One also needs to consider that some specialties are more amenable to telemedicine than others. Certainly, psychiatry, where it's largely talk-based therapy, that works really well with telemedicine. Endocrinology, where it might be more laboratory-based, that might work well too. Obviously, you want to do some physical exam with endocrinology. There's other specialties that just don't work well with telemedicine at all. Ophthalmology, kind of hard to provide ophthalmologic services with telemedicine. Orthopedics, that also might be helpful for diagnostic, but you're seeing orthopedics because you want treatment, and that might be difficult to provide by telemedicine as well. So I think that's where there are some limitations as well. In my specialty, I feel comfortable with my return patients, but if I had to, if someone's referring me for a
I think we froze up a bit.
Yeah, well, we lost Brian again. I told him, I promised him I would finish his sentences. So, in cardiology, we have the ability to see patients remotely. There are some legal barriers. The Cleveland Clinic has a very large international practice, so we've had to solve some of these problems as well. During the height of the pandemic, more than 50% of our outpatient visits were actually being performed via telemedicine. And what's actually happened is there's been an explosion of improvements in technology. The various platforms that are available for telemedicine have gotten better. looks like we've got Brian back. So Brian, I told you I'd finish your sentences for you, and I did. I'm just commenting on the fact that we had at the peak of the pandemic, about 50% of our outpatient practice was telemedicine. And we have actually been a bit more liberal about overseas, mainly because the clinic has this very large overseas presence. And so it's been a little bit easier for us to do that. We have a hospital in London, we have a hospital in Abu Dhabi. And so there is quite an international legal team that can actually support us in some of that activity.
Well, Steve, I could hear what you were saying, and as predicted, you are effective in reading my mind. So thank you for
Well, good, very good. I'm glad, this is a great way to overcome some of these technical glitches, to have a friend and a colleague who's a mind reader. So, well, Dr. Yedekam, a lot of this telemedicine, COVID-19, doesn't specifically apply to your work because, having babies come in with heart conditions, operations, all of that has continued. But, do you have any thoughts on what possibly we could see in terms of COVID-19 developing with babies and children in the long term, or is it just too early to really speculate on that? And then also you mentioned you've got big plans. So we'd love to hear about some of those plans and some of the innovations you hope to bring to fruition here in the U.S.
So that's two very different questions. But the first thing is that, and I don't know what Dr. Choi and Nissen think about it, but as a reminder, I'm the worst case scenario. You're talking to somebody who phoned his wife on the 3rd week of January to mention to buy a mask in the pharmacy because I was feeling that something was growing up. But I had been waiting for years that a pandemic was coming up because I was working with a world specialist in infectious disease. So I have a particular background. But in Washington, D.C. now, in the Children's National, we have identified that there's an inflammatory reaction that happens in children. And we had some of these baby and adolescent and really sick. I mean, some of them we had to put on ECMO. Not the majority of them escaped ECMO, but we had to put some of them on ECMO. And they're not the first infection, not exactly the myocarditis you see. But and I don't know what stage of the research, I'm not central to that research, but the people have said that maybe when you get a reinfection, this COVID infection there's a lot of inflammatory reaction. Maybe when you get a reinfection, you actually may be more susceptible to a more generalized immune reaction. And I say to my kids, I know you think you're going to be protected and completely immune, but you don't want to catch that disease. You don't know. I think we have no idea what it's going to do to your health, and in particular to the heart 20, 30 years down the line when you have repetitive infection. I don't know, but I think that's a question that remains open now. I don't think you want to catch it. Do you disagree, Dr. Nissen?
And in fact, something we probably ought to talk about here is this syndrome known as long COVID. And I would guess that all of the participants here are well aware of what's going on, that these patients, and we don't fully understand it, but they seem to recover from the infection, but then they have all these lingering symptoms. Some of them are cardiac, and many of them are neurological, and they don't feel right, and they don't seem to be able to get back to their previous health so quickly. I'm not sure how much of it is physical and how much of it is psychological. There's a lot of things we just don't understand.
Thank you. And so if I can get to your second part of your questions on what I want to do is, so I'd like to break the ceiling of this seemingly unsurmountable ceiling of the mortality in this single ventricle mortality. And my plan for that is that there's the first thing to do if you want to, in this complex condition, have a good rate of success is you have to have a team, and it's a teamwork that has to work like a Swiss clock. And you can get survival on these patients, but you have no room for mistakes. So that's a bit the excitement. And just by excellent practice and teamwork, you can achieve something. Then the other thing is that I'm a big data person. So I've collected the largest data set of this type of patient on a long term. And I'm building up an international frontline registry here with most of the major North American institutions who have their data. And large, there's benefits of having large data. We can identify best practice. There's a lot of questions. It's been 50 years we're doing this kind of work, and there's still, we don't know at what age is the best to do this operation. Do we have to put a hole here or not? And so there's a lot of questions that needs to be solved. Then the other thing is I'm a machine guy. So I like little artificial hearts because I trained in Belgium in a European Center for Novacor. I'm sure Dr. Nissen remember that was a huge machine that we're putting in really big people. And now we have some device for children, but we are developing now, and I'm proudly saying that I'm the clinical lead of a small device that is the initial development has been funded by the NIH. It's a size, AA battery that we could put in small babies. And so in children, it's always a question of time. There's a lot of conditions that if you think the baby, give me 6 months or 9 months, and there's no problem for solving the issue of the problem, because it's a problem. A lot of this problem is a problem of size, and so there's a lot of these babies who are dying now. If we manage to support them with artificial hearts for 6 months to a year, we can change the perspective. But I think we need new solutions to the problems we have now. We have to think outside the box, and I have 10 to 15 years to do that. So I hope I'm going to get there.
That's a long time frame. And to kind of, I think for average people, hard to wrap our minds around, putting a small battery in a baby's heart. So these are really exciting developments and lend some optimism. Obviously we've been dealing with heart disease, and your research has, decades, and we're going to have probably decades to come now of research on COVID-19. But I think, personally, I'm optimistic hearing about all of these developments, and certainly they're fascinating. So I want to thank the three of you for joining us and enlightening us on some of your work and your projects. And so we are actually going to transition, so I can kick my cat out of the room here. We are going to transition into a 15-minute break. I would encourage you can visit the expo booths where you get all kinds of various information from our sponsors. And you can also click into our networking session, and you will be, speed business networking. It's a really great way to connect with people. And you'll just be randomly paired with somebody for 3 minutes, and you can connect, exchange profile information. You can extend the time if you wanted to continue your conversation. So it's a really fun platform, and not quite the same as in person, but I think it's pretty close, and you'll get a chance to really meet a lot of different people. So again, wanted to thank everyone here, and please stay tuned for our next panel.